children with tubular. So with this learning objectives, I will start by this introduction. We've seen from nephrotic syndrome, and we've seen from acute kidney injury presentation, Dr. Rashid presented with all the tubular diseases, the glomerular diseases, that there is a signature of the glomerular disease in the clinical presentation. The major signature of the glomerular disease in general is a lot of times there is a lot of excessive protein in the urine. And then the sequence of events happens. Could it be resulting in acute kidney injury, or could it be resulting in nephrotic syndrome? The other face of the coin is the tubular diseases, which is, if you remember, the glomerulars filtration to the tubule. Now it is the job of the tubule to claim back all these filtered substances, fluids, and nutrients that the body will need. So any tubular disease will have mainly problems of the tubules that it's supposed to do, which is mainly the reabsorption of certain electrolytes, the control of the acid-base balance, and also, as we're going to see, that certain diseases can happen, such as hypertension and chronic kidney diseases in this tubular dysfunction or tubular diseases. Therefore, the clinical presentation of the tubular diseases is very wide. It can present early in life, and we've seen it in neonates sometimes. And as we go during life, in the first few months of life, to few years of life, and sometimes late presentation in early adulthood, that can happen. Most of the time, and we like you to remember this about the tubular dysfunction, most of the time, or a lot of times, there is a genetic cause that can be attributed to this tubular diseases. However, we've seen and we know that there is sometimes acquired forms due to other diseases, as we're going to see, or due to medications. You have to remember that certain medications we use as physicians to treat certain problems, and specifically diuretics, their main job is to block the normal function of the tubules. So in other words, they create for us a disease-like presentation if we use it without medical care. So you don't over-the-counter use them, people use these medications, or if these medications are used to treat other conditions, we have to remember that the side effects of these diseases, of these medications, can present as a clinical presentation. Yet, a genetic mutation in that transporter that the medication is working on can give you a disease presentation. So the presentation could be as wide as electrolyte abnormalities, whether this electrolyte is sodium, potassium, or there's chloride, magnesium, phosphate, calcium, and so forth. It can be due to a defect in the concentrating abilities of the urine. So patients might develop dehydration, as we see in diabetes insipidus presentation. Patients do have a problem from a nephrological cause in the response of the antidiuretic hormone. This patient can present with severe dehydration. Metabolic acidosis can be the presentation for these patients because part of the responsibility of the kidney is to control the balance of the acid base in the kidney, whether it's proximal tubular, whether it's distal tubular, and we're going to dive in a minute in this topic in few minutes. Or it could be alkalosis. A lot of times we think about acidosis and we forget alkalosis, as we think acidosis is more important, yet alkalosis can be of clinical significance and have a significant presentation and side effects in the whole body. The importance of alkalosis and acidosis balance, you guys, if you remember from your education, there is a respiratory component and there is a metabolic component. Whenever we're talking about the kidneys, we are talking about the metabolic component of the acid-base balance. The respiratory is due to lungs and due to other diseases, pulmonary diseases. The metabolic, the kidney is of a critical place to control the acidosis. Why alkalosis and acidosis are important? Because almost all our enzymes that works in our body, and specifically in children, are pH dependent. These children need these hormones to grow. So a lot of times when you have acidosis or alkalosis, the enzymes that's needed for a child to grow or to have the normal metabolic processes, then we do have a problem with growth. And if you're going to remember one important thing about pediatrics, that growth is of great importance. Why? Because when you look at a child, you want to know this is acute or chronic problem. You got to look at, especially when it comes to other diseases, you have to look at the growth. If a child is growing normally, then most likely you're dealing with an acute problem. If the child is stunted in this growth, then most likely you have a problem that's of chronic nature. So pay a lot of attention to alkalosis and acidosis in these patients or in these children, as pediatricians in general. Sometimes tubular disease can present you as hypertension, and we're going to see that there are certain receptors or transporters in the kidney that if we have a defect in them, those patients having problem of retaining salt and hypertension. And Nasreen will talk to you later about hypertension in children. Now, sometimes chronic kidney disease can present, and specifically when we talk about medullary cystic renal disease, this is typically a tubular problem. It's not glomerular disease. It's most likely a tubular problem. And if you remember, one of the roles of the tubules is to control the hemoglobin production, erythropoietin control. If you remember, the enzymes responsible for the erythropoietin production lies in the tubules. So if you have a problem on the tubules, especially if it's a chronic problem, you will end up, and specifically medullary cystic renal disease, your clinical presentation most likely severe anemia associated with chronic kidney disease. So put that in mind whenever you're dealing with a patient presenting to you. You don't know. It is an acute problem I'm dealing with. This is a chronic problem I'm dealing with. This is a glomerular problem I'm dealing with. This is a tubular problem I'm dealing with. Is try to put everything together as a puzzle and try to understand where are we on that clinical presentation. So usually one of the most important things about the glomerular disease and the tubular disease that you do not usually need a kidney biopsy for diagnosis. Tubular disease is different from the glomerular disease by the fact that you can put the clinical presentation alone, do your blood and urine test, then you can come up with what most likely the cause of the tubular disease. Ultimately, genetic testing will be needed to confirm certain diseases as genetic causes for it. But in proteinuria, for example, or glomerular disease, a kidney biopsy will be warranted at some point, especially if they present with abnormal kidney function or unusual presentation. So with that in mind, I'd like you to look at this slide with me, and we're going to take the journey as we go here. The filtration takes place at the level of the glomerulus, down here, and as soon as it comes out from the glomerulus, it comes to the proximal tubule, and it goes through the loops of Henle, and it comes into the distal part of the nephron, and then as we go down to the collecting ducts. You have to remember that this is the cortical area, call it the cortex. This is the medullary area or the pyramid part of the kidney. Diseases affecting the glomerulus will be mainly resulting in proteinuria. Diseases affecting the proximal tubule will be, we look at what does the proximal tubule is doing, and then we look at what is the presentation looks like. A lot of reabsorption takes place in the proximal part of the nephron. Why? Because the body is trying to reclaim back the most important parts. The whole concept is that it is all mixed together. The toxins, the waste products are mixed together with the blood. So God made it in a way that it get all filtered. And then in the proximal part of the nephron, the reclaiming of the most important parts, the sodium, the phosphorus, the glucose, the proteins are very much reclaimed in the proximal part of the nephron. Now it is left for the distal part of the nephron to fine-tune certain things, and at the level of the distal nephron, here is going to be the handling of the water. That's why the antidiuretic hormone is mainly working in the distal part of the nephron, the collecting ducts, and the proximal part is handling all the sodium. Yet we gotta have to look at certain fine-tuning. For example, distal part of the nephron, collecting ducts, if there is a defect, as I mentioned earlier, in the sodium-potassium channel over there, or transporter, and you stop reabsorbing the potassium, the sodium, you will end up having significant hypertension. Again, if you have a problem in the proximal tubule, excessive wastage of sodium, of bicarbonate, of where the reabsorption takes place, is going to be the presentation. Phosphate will be the presenting phosphate. So if you look at the urine that comes out from the child, you will be able to try to put it together to fix where would be the problem. This is, if you get this slide understood very nicely, then the whole topic is covered. Simply, filtration takes place at the glomerulus, comes into the funnel of the tubules, and it, as you go as a filtrate through, significant number of bicarbonate get reabsorbed down here, and it goes in, and there is an enzyme called carbonic anhydrase inhibitor. If you guys, carbonic anhydrase, the carbonic anhydrase then, with the presence of water, will make it CO2 and water for it to get reabsorbed back in the proximal tubule, and I'm going to show you that later. Now, if you use carbonic anhydrase inhibitors, that will work here. You will have a proximal tubular diseases. And there is genetic diseases that can cause carbonic anhydrase inhibitors, and there are medications that we use that can give you carbonic can cause carbonic anhydrase defect. Or sometimes, if you have a problem with the tubule themselves, the absorption of sodium bicarbonate get affected. Mainly the bicarbonate in this part. Almost 70%, 65 to 70% of calcium get claimed back, reabsorbed into the blood, into the circulation back in the proximal part of the nephron. In the loop of Henle, again, you have the sodium chloride channel in the thick ascending loop of Henle, where a reabsorption, this is where the loop diuretic works. So if you have a problem here, or if you have a defect in this transporter, whether it's a genetic cause, or if you are excessively using loop diuretics, you're going to have a problem here. And bear with me as we go down here in the distal part of the nephron, because here around 5% get reabsorbed through the sodium potassium transporters down here. And again, this is where the thiazide diuretics work. So there are certain diseases that can affect the tubules here as a genetic cause, or iatrogenically if we are using thiazide to treat other causes or diseases, then the clinical presentation will be similar to a genetic disorder. Now, this is the part where the sodium potassium control is through the aldosterone. And the aldosterone is, again, if we remember, their job is to reclaim back the sodium. So if you have a defect in it, you will have a problem with the potassium, reclaiming back the potassium, as you can see it here, and getting rid of this aldosterone of the sodium. So the end result, if you don't, you're going to have a problem with aldosterone. Excessive aldosterone will give you hypokalemia. And if you guys remember that if you have diseases of aldosterone, or if you have used potassium-sparing diuretics, the potassium secretion will be affected and the patient can present with hyperkalemia. Now, ADH and the control of ADH takes place here. Now, this is the cortical part or the proximal part. The medullary part is here for the concentration. And here the water goes in and out according to the demands of the antidiuretic hormone or the medullary concentration and osmotic gradient. I don't want to get in depth with all this because I like to make sure that we put this all in perspective. So let's start with just a very common clinical presentation that we always see, that a mother will bring her child to you who is 9 months of age, male, is coming because failure to thrive. And again, every time you face a child with failure to thrive, it could be anything. However, the thing that can be easily detected is the thing that we can fix or can treat. And failure to thrive is a big topic. Endocrine will fall into it. However, as a nephrologist or as a pediatrician in general, and let me widen it up to the whole audience here, that one message I was told about younger in my career, that if you want to be a good pediatrician, look at the growth of your child. This is an important thing for you. A child who's failing to thrive, not growing right, it's your job to figure out why and how can you fix it. This child presented and the mother tells you that he has no vomiting, he has normal bowel movement, and he's urinating excessively. And the way she described it as excessively, that she is changing diapers a lot. You have to remember, this is the first child for this mother, because you ask her and she said, it's my first child, so she doesn't know. But she noticed that the diapers are heavy and he has no respiratory symptoms. While you're asking the history, and in any child, especially in their first year of age, part of your history is the pregnancy. How was the pregnancy? Was it a normal pregnancy? Was it complicated by any problems with the child, the baby, the fetus at that time? Were there any polyhydramnias? How was it, normal delivery or not? And here the mother tells you that he has normal, everything was fine. However, they told me I have excessive water, polyhydramnias. Now, the child otherwise is fine. He's always has been noticed through his evaluation that his weight is on the lower side. That's the only presentation. And then as you go and assess him, and his family history was unremarkable for any other diseases. His weight was 6.2, which is less than 5th percentile. Always try to plot them into the growth curve. His height is 65 centimeters, which is less than 5th percentile also. His blood pressure was 85/50. This is a normal blood pressure for a 9 months of age child. His heart rate is 109, not tachycardic. His respiratory rate was around 20s. The most important striking feature for you that you notice that he's small for his age. You do an examination of his chest and heart and abdomen, and the examination is completely normal. You do a neurological exam, it was completely normal. You do an assessment for his extremities. He has full range of motion of all extremities, and there is no lower limb edema. You go and investigate, and we do complete blood count, and your blood count completely normal. Your electrolytes, his sodium is 131, potassium is 2.8, significantly low. His chloride is 89, which is low. His bicarbonate is 36, which is high. His BUN is normal, his creatinine is normal, his calcium is normal, his phosphate is normal, his magnesium is low, 0.45. You do his urine analysis, there is no proteinuria in these patients. The rest of the examination was normal specific gravity and so forth. You start to think that, as I mentioned earlier, that let me look at the urine of this child. You do a urine electrolytes, your sodium is 70, which is high. The chloride is 83, which is high. Potassium is 23, which is high. You requested an ultrasound, and it is a nephrocal stenosis. I could have made this case more of an interactive to ask you, what would you do first? What would you do next? But I thought, as the first case I'm going to be discussing, let's try to put this case together. From the history of this patient, we have failure to thrive. We have, by history, that's why history is very important, excessive urination, nothing else. There is no diarrhea, there is no vomiting. A lot of times when you have failure to thrive, the bowel movements are very critical, because if they have chronic diarrhea, that will direct you towards a certain line of thinking. If there is excessive vomiting, you start to think about what could it be from the GI tract. Why respiratory symptoms are important? Well, chronic lung disease can be presenting as failure to thrive also. Now, you put this together with, from the history, polyhydramnions during pregnancy, and then you come failure to thrive here, and excessive urination down here, normal blood pressure, and no other finding, no proteinuria. And the most impressive presentation here you have is this hypokalemia, and it could be very low, and the alkalosis that we have and the chloride. Then you start to think about, this is a tubular problem. This is not a glomerular problem. It does not look like a GI, does not look like a lung pulmonary problem. This is a kidney problem. Normal kidney function so far. Phosphate is normal. There is no problem of phosphate wasting down here. But I have a problem with magnesium here, low serum magnesium. Now, excessive sodium to this degree and excessive potassium. This will directly towards, I don't know if you can have the chat so you can give me your feedback. Can you text in the chat to see what you have in mind, so at least we can see your response? Excellent. So significant number of people have nailed the diagnosis, which is Barter Syndrome, and there is some of you mentioned type 2 renal tubular acidosis, which is exactly the reason I put this patient as there. Some people put Gitelman syndrome versus Barter syndrome. Excellent. This is a very good start for our discussion. So this patient did depict the presentation of Barter syndrome. And sometimes we don't think it's that common, but trust me, it is common. It is relatively common, especially if you don't pick it early in life. These patients usually, an autosomal recessive, there is different types of it. And I do not want to dig into the types of Barter syndrome. Every now and then we have mutations that results into, but in summary, it's an autosomal recessive renal tubular disorder characterized by significant hypokalemia, hypochloremia, and metabolic alkalosis. For those who answered renal tubular acidosis, the answer is in their answer, which is you have to have acidosis to call it renal tubular acidosis. And we're going to talk about renal tubular acidosis in a minute. But significant metabolic alkalosis, and for you to diagnose metabolic alkalosis, you have to do a VBG or a capillary blood gas to confirm that the pH is affected and that and it has to be a metabolic one. Remember I mentioned exclude respiratory alkalosis, and you can see respiratory alkalosis in a lot of diseases in the lungs as well as other diseases. Now, metabolic alkalosis, hypochloremia, and hypokalemia. Wherever putting the chloride and the potassium together, you start to think of this is a tubular problem I'm dealing with. Those patients with Barter do have hyperreninemia. The renin is very high on these patients. The problem happened earlier in life during the formation of the kidney. So there is almost like the juxtaglomerular apparatus where the renin is produced, become blunted. Yet there is a lot of excessive renin without the effect. And we all know that if you have hyperrenin status in your blood, the renin will ultimately result in angiotensin II production, and the angiotensin II product is vasoconstrictor. But why in Barter here, we don't have hypertension? Characteristic of Barter, there is no, although there is hyperreninemia, there is normal blood pressure. This could be attributed to a lot of reasons, some of them that the prostaglandin is also upregulated in this patient, and the prostaglandin counter the effect of balance the effect of the angiotensin 2. So the effect of the angiotensin 2 is more or less blunted. And that prostaglandin is considered as in the pathophysiology of it. Whether which one came first, the chicken or the egg, still people are trying to put it together. I do not want to get you into the nitty-gritty of the details about it, but the end result is a prostaglandin that's up. That's why if you want to treat it, think about something to block the prostaglandin. Renin production, that's why if you want to treat it, think about something that will block renin-angiotensin system. Yet you're going to have a problem of wastage because there is polyuria, there is polydipsia, and the patient almost most of them develop a failure to thrive. But polyuria and polydipsia are what's keeping this child in balance, because if the child doesn't have access to fluids, this patient will present with excessive dehydration, especially if they develop any symptoms of vomiting or diarrhea. Then they will end up having dehydration as their clinical presentation. That's why you got to look at their urine. If they're just a dehydration, you expect the sodium to be reabsorbed, chloride to be reabsorbed. But when you find excessive urine sodium, it tells you, no, this is not just dehydration, this is wastage. What we call it, salt wasting tubulopathy, that the tubules is wasting sodium, wasting chloride, potassium, and sometimes calcium. That's why these patients develop hypercalciuria, and their sodium and potassium are affected. These patients are prone to hyponatremia, hypochloremia, and metabolic alkalosis. Now, why metabolic alkalosis? Because we have to remember that when we are dealing with Barter, we are dealing with a disease that causes, depending on the cause, the chloride wastage. So what happens? What happened that if your defect, let's say that the Barter problem is happening here, the body is trying and you're wasting a lot of chloride going into the tubules because the transporter here is reverse. The other direction, the chloride will come here. And so the end result is the chloride being the negatively charged. The body is trying to reclaim back a negatively charged material, which is the alkalosis, and that takes place excessively in the proximal part of the nephron down here. In certain types, hypomagnesemia, and around 1/3 of the patient with Barter present with hypomagnesemia. And that's why, again, if you examine the urine, you will have there is increased magnesium wastage. Again, a lot of times it happens that it depends on all. If you guys remember, when we use loop diuretics, the side effects of the loop diuretics is magnesium wastage. So if the defect is here, you're going to have a problem with magnesium wastage also. Now, for those who answered, Gitelman syndrome is absolutely can be right. However, usually Gitelman presents a little bit later in life. A lot of time, those patients, and we have to, again, it is the defect in the Gitelman syndrome. I want to make it to you. It's down here in the thiazide area. So your defect in the thiazide area result in Gitelman syndrome. The clinical presentation of Gitelman could be usually later in life. Those who have a problem of Barter syndrome tend to have excessive, because around 25% here, and can present early in life. Gitelman, in comparison to Barter, the calcium in the urine is significantly low. You guys remember, if we have patients with certain tubular diseases resulting in stone formation, hypercalciuria, we treat them with thiazide. Those patients who are taking a lot of loop diuretics, they develop stones down the road because they have hypercalciuria. So if you excessive use diuretic, loop diuretic, furosemide, for example, as an example, you will have hypercalciuria. And think about Barter. You excessively use thiazide, you will have hypocalciuria to treat the excessive calcium, and you develop a Gitelman-like syndrome. These patients can be older in age and so forth. And sometimes even adulthood can have presentation of Gitelman. But the most important part is that there is hypocalciuria in these patients. The management of Barter. Fluid management is of great importance. Those patients end up needing a lot of fluids for them to grow. You have to remember, a dehydrated child, an alkalotic child, cannot grow normally. They have to have enough fluid in their system. Sometimes you might need to place gastric tube in these patients because this is a young child who cannot keep up with the amount of fluids that actually get wasted. And your nutritional support is of critical importance in these patients. Treatment, non-steroidal anti-inflammatory medications as a prostaglandin inhibitors that are used, whether it's endomethacin or other types such as ibuprofen and so forth, and ACE inhibitors, amyrolide, which is amyrolide works in this part of the nephron, the ENaC down here. Spironolactone works down here to spare the potassium on these patients. And these are the mainstay treatment for Barter syndrome. In an eggshell, for Barter patients, always think about metabolic alkalosis, hypochloremia, hypokalemia, failure to thrive. If you check their renin, you'll be very high. However, the blood pressures will be very normal on them. If you check your urine electrolytes, they'll be excessive, including calcium, to differentiate it between Gitelman, which is hypocalcium, the calcium in the urine is low, and you have most of the time, sometimes on 1/3 of the patients, sometimes you have hypomagnesemia as an initial presentation. Whenever you have hypomagnesemia, what comes to your head is Gitelman also. So hypomagnesemia put in your head. Now look at the other findings, whether if I want to differentiate between Barter and Gitelman, look at the calcium in the urine, and that will give you the clue where you're going. But this is an early indicator. Just another case as we go. 9-month-old male present with failure to thrive. Again, like that one before. He has no vomiting, normal bowel movement to exclude any GI losses. Yeah. No respiratory symptoms, past medical history, the first child, almost like that one. Normal pregnancy, normal delivery. Family history is unremarkable. And his weight is less than 5th percentile, same like that one, same height, less than 5th, normal blood pressure, same vitals. He's small for age. His chest, heart examination of the abdomen was normal. Neurologically is normal, and so forth. Now, you requested the same investigations that you did it for the previous patient, so since you can have a clue what you're dealing with. Electrolyte sodium was 130, potassium was 3, chloride was 110, bicarbonate is 13, BUN 12 is normal, creatinine 23 millimole per liter normal, calcium 2.1 normal, phosphate 0.8 is low. Urine analysis relatively normal. There is some trace protein. Urine electrolytes, sodium, it was 35, chloride 23, potassium 15. Renal ultrasound showed echogenic kidneys. Again, what do you think is going on with this patient? So we can have some people said RTA, CKD, RTA. So we are, most of the people, and the people are very, this time are very conservative. They said RTA. They did not tell me what type of RTA proximal, except one person said Fanconi and one person said type 2 RTA. Now people are more into it. Exactly. So let's just take it from here. This patient is presenting with renal tubular acidosis. And there are 3 forms of renal tubular acidosis that I'm just going to discuss with you. That the proximal part, which is called type 2 RTA. And a lot of people think, why the proximal is called type 2? They like to confuse us. We think the proximal should be 1, the distal should be 2, and then whatever 3 and 4 should be there. However, when they discovered this type of this RTA, the first one was discovered was distal part of the RTA, renal tubular acidosis. That's why they call it RTA at that time. Then they discovered the second one, which is the proximal after that. Then they relabeled the first one as to be type 1, and this one is type 2. And then sequence of event took place. People labeled type 3 RTA, which is the one that involved the carbonic anhydrase inhibitors. And they found that carbonic anhydrase can work in different parts of the nephron, proximal of tubule. And lately they found that, no, we are not going to deal with the type 3 because type 3 can be either proximal, it can be either distal. So they omitted the diagnosis type 3. And that's why you're not going to find type 3 as present. You're going to find type 4, which is the hyperkalemic one. The hyperkalemic one is an aldosterone effect down here. Remember, hydrogen ion transporter here is going to be affected, which is, again, can be related to aldosterone or a defect in the hydrogen ion secretion. This is type 1. Or if you have an aldosterone effect, then it becomes type 4 because now potassium is also affected. Now, the proximal part, this is when we talked about if I have a defect in the proximal part of the nephron, and one person said Fanconi, which is exactly what the common cause of the proximal tubulopathy or proximal tubule defect is Fanconi syndrome. And the distal part is the hydrogen ion excretion is affected. Now, what happened in metabolic acidosis? Why it is of importance for us to know what's the role of the kidney? Well, under normal physiological circumstances, it is the responsibility of the kidney for the buffering of the acid that accumulate in our bloodstream every single day, continuous 24/7. And usually the titrable acids that we can measure is usually around 2 milliequivalent per kilogram per day. For children, could be even higher depending on their metabolic rate, which is the amount of acid load that comes into the system. Then this is the responsibility of the kidney to excrete it in the distal part of the nephron, in the distal nephron. In adult, their growth is kind of little bit done, so they have almost 1 milliequivalent per kilogram per day. And that's why acidosis is not of great importance for adults. Yet it's important, but for children, as I mentioned, because they are growing, all these growth enzymes, all those materials will be affected because of the pH of the patient, especially if they're acidotic. Now, the reclaiming back of the bicarbonate, around 90% in the proximal tubule, around 10% in the distal part of the nephron. Again, carbonic anhydrase is the mechanism that it gets reabsorbed with. And the kidney excrete hydrogen ion in the distal part of the nephron, as the amount will come back again, how much you have. It cannot excrete it directly. And that's why it utilizes ammonia as a proton, a proton trap. It trap it to make it ammonium, and then ammonium cannot diffuse back into the cells. That's why hydrogen ion gets lost at that part of the nephron. Now, how do we evaluate it? Well, the parameters to assess is the pH of the metabolic acidosis, the PO2 to differentiate between it, whether it's a metabolic or it is respiratory. And a lot of times we see that when you have a metabolic acidosis, your CO2 get washed out because you develop what we call it cosmal breathing. You excessively breathe faster and intermittent breathing. So the end result is washing out of CO2. The bicarbonate will be low. You have to have a low bicarbonate to call it metabolic acidosis. And most of the time, you have to look at what is your anion gap in this. Whether it's a normal anion gap, which is 12 plus or minus 4. Say, in other words, 8 to 12, 8 to 16. So if you have a normal anion gap, that tells me, well, there is two reasons here. It could be either the kidneys or the gut, because that the kidney is trying to work out to balance it. Now, if you have a high anion gap, then you have to think about other causes, and I'm going to mention it in a minute. You have to have a low pH, a low plasma bicarbonate for the definition of metabolic acidosis. Usually, the lungs lower PCO2 to minimize the fall in the pH. Usually, PCO2 falls from 40, normal, in parallel to bicarbonate falling from 25. So as you go on this low, that one falls to compensate for it, that wash out, because you do not, as I told you, CO2 plus H2O in the right enzymatic characteristics will result in HCO3 and hydrogen ion. The kidney secrete ammonium to keep normal acid load in 70 millicurie in adults, and in children could be even higher. And it must match the acid load. So if you produce more acid, okay, then it should be more excretion of hydrogen ion, and it can increase up to 4-fold if you have acidosis. And that's important for you to remember when you're evaluating these patients. When do we think that, well, there is a high anion gap? Well, it could be due to other things. How do we measure the anion gap? Sodium, and then chloride and bicarbonate. As I mentioned earlier, any number between 8 to 16. So any number above 16, we call it high anion gap metabolic acidosis. And a lot of causes can give you this: methyloruremia, diabetic ketoacidosis, formaldehyde, inborn error of metabolism. This is important for young babies who are coming to you, iron intoxication, lactic acidosis, as in patients inserting inborn error of metabolism, or lactic acid affection, especially in patients with cardiac dysfunction, ethanol glycol, salicylate poisoning, and it can go from, in salicylate, it can go alkalosis, acidosis, as you guys remember that very well. So in normal anion gap metabolic acidosis, then you have to think about, is it diarrhea? Well, if it is diarrhea, then you know that's not the kidney. A child presents you. That's why it's important to ask whether there is diarrhea or not. Urine anion, and this is usually an acute issue. It's not chronic. If it's chronic, then this is something else, something causing this to be in the GI tract. Urine anion gap, in certain time, you have to remember what's the urine anion gap? Urine anion gap is you measure the sodium, the potassium, and the chloride. The end result is a negative number. Now, it means in certain situation that chloride is high and your sodium and potassium are less than chloride. This, when that happened, because you have a bicarb that you did not count for. then you know that there is a negative number. Now, the problem that if you have a positive number, that means what? That means sodium and potassium are high compared to the chloride, which is negative. That means there is no room for the hydrogen ion to come. That means there is no excretion of hydrogen ion into the urine. That would be the problem of the distal part of the nephron. Now, in the renal tubular acidosis, the proximal part, if it is due to proximal part, can occur as a tubular defects, as we said, and usually occur acetazolamide, as we mentioned. These are the inhibitors for carbonic anhydrase. Urine pH may be normal. Why? Because it could be alkalotic, depending on the threshold. That if you exceeded your threshold, the carbonate can come down. But if you reach the threshold, it can be normal because you are not there. And the distal part of the nephron is normal, and it will be able to acidify the urine. It could be normal acidification of the urine or an alkalotic part. We have a problem in the distal part in your, if you to make in the bicarbonate in new one. But I do not want you to concentrate on this part. I want you to look at the proximal part defects is isolated bicarbonate wasting, and it is usually rare, usually part of the proximal tubule defect. And the Fanconi syndrome is what is the presentation symptoms. To have it just for the bicarb is not that common, but to have it together and Fanconi as wasting of bicarbonate and phosphate wasting, and our patient who we discussed have the low phosphate in the urine, in the blood, and if we measure the phosphate in the urine, what we call it tubular reabsorption of phosphate, which is, in other words, how much phosphate is being wasted, we'll find that there is a lot of wasting of phosphate. I do not want to get into the calculations for all that. Those patients, as I mentioned, the proximal part is responsible for glucose reabsorption, amino acid, and uric acid. So that's why you have a defect in phosphate, glucose, amino acid, and uric acid also. Major causes of type 2 RTA could be primary, which is not that common, inherited Fanconi. What can cause Fanconi? Cystinosis, hereditary fructose intolerance, different diseases, glycogen storage disease, Wilson disease as the liver copper metabolism, Lowe's disease. And I have very interesting slides, but for the sake of the time, I'm not going to be able to show it to you, to explain to you all these disease and why it happens in the tubules. Maybe one day we'll talk about it more in depth, but because of the time, I want to be focused on what you're going to see at presentation for those patients. Acquired disorders, hypocalcemia, vitamin D deficiency has been shown to be associated with type 2 RTA. Drugs, certain medication, toxins, and outdated tetracycline, lead, mercury can give you defects in the proximal tubular, and Sjogren syndrome can be one of the rheumatological causes for proximal tubulopathy. And sometimes I have patients with FSGS do have proximal part defect. So can be a mixed forms of tubulopathies in certain glomerular disease. Do not want to confuse, and let's focus on type 1 now. The defects in the distal nephron associated with hypercitraturia and nephrocal stenosis and nephrolithiasis. This is the one that we know it could be sporadic or could be hereditary. There is familiar form, Marfan's, Wilson disease, Ehlers-Danlos syndrome has been associated with distal part of the nephron. The characteristic part is those patients develop nephrolithiasis. And those patients, if you calculate their and the urine anion gap, it will be a positive side in the urine anion gap. And that means there is no way for or a place for hydrogen ion to be coming out. Most of the time, we have to remember that in disorder of calcium and nephrocal stenosis can be associated or can be caused. There is something called familial hypercalciuria, primary hyperaldosteronism, and primary hypervitaminosis D, and medullary sponge kidney, and which is rare in children that we see it. It can be associated with this renal tubular acidosis type 1. When I see a nephrocal stenosis patients, I think about type 1 artery. I have a problem with the distal part of the nephron. Autoimmune disease, we mentioned it, and SLE and thyroiditis can be as antibodies, and people think maybe there is antibodies attacking that part. Now, amphotericin B, and again, those who works in hemonc floors will have a problem with certain chemotherapeutic agents can be causing distal part of the nephron. And sometimes lithium, we know as part of the medication used in psychiatric treatment. Urinary tract obstruction can be associated, but associated with hyperkalemia is usually a distal part of the nephron, and that's type 4 RTA, sickle cell syndrome, lupus. Any marked volume depletion of any cause can give you type 1 RTA. However, type 4 associated with hyperkalemia due to either to hypoaldosteronism or tubular resistant to aldosterone. The causes are mild to moderate renal insufficiency, especially diabetic nephropathy patients, obstructive uropathy patient with posterior valve obstruction. Any kind of obstruction can give you type 4 renal tubular acidosis. And if you want to remember type 4, it is the cousin of type 1. However, the defect is in the aldosterone, and you have a problem with potassium excretion. Sometimes congenital arterial hyperplasia have to be, you think about it, and tubular interstitial nephritis is there. Just a look fast because of the time. If you look at the distal, usually decreased distal acidification, the pH of the urine could be more than 5.3. And in the proximal part, it could be more than 5, but it could be, according to threshold, could be low. Patient with type 4 usually less than 0.5 because they have a problem with aldosterone only there. So they're able to acidify the urine. Now, the plasma bicarbonate will be very low. Most of them, they can be low, and you cannot differentiate only by volume, but it can be very low in certain diseases and so forth, but if untreated. Now, in patients, if you want to see how much actually I'm having a problem of it, you can give bicarbonate load, and if the bicarbonate load, if you give small doses and correct it, then you're dealing with either type 1 distal or type 4. For proximal, you need big, huge doses for you to have it. Nephrocal stenosis is characteristic of type 1, but it can happen in the other ones, but not characteristic for them.
يا دكتور أبو بكر.
Yes.
الشباب ده بدأ انك تقف كلها في التعليقات يا اخي ارجوك ما تقف ارجوك ما تقف فكلهم شغالين كده فتيك يور تايم يعني. الدنيا برا مطر والشوارع مويه فما عندنا حته نمشي فيها.
Okay, but I don't want to be boring for them.
لا والله بالعكس it's very very interesting والله بصراحه يعني حتى شوف الناس كلها بصراحه ما انا برايي بصراحه it's very nice والله حتى انا مستمتعين والله فبالعكس don't rush والله بصراحه يعني.
Okay, so when to suspect renal tubular acidosis? Whenever I have a normal non-anion gap metabolic acidosis, you look at your sodium minus chloride plus bicarbonate. If it is 12 plus or minus 4, in other words, any number below 16, let me just put it to you as simple, any number below 16. If it's more than 16, then there is an anion gap. It's less than 16, you have a normal anion gap. Your differential diagnosis, ask the patient about diarrhea. Do not just assume it's renal tubular acidosis. Because I just mentioned, sometimes just volume depletion itself can give you distal tubular renal tubular acidosis. And lactic acid production, all that can happen, and it can be falling into the dehydration just not there. It's almost like 15, close to 16, but you cannot detect it based on just a number. Must confirm that the patient is acidotic, and that's why a CBG or an ABG or a VBG can be of help for you here. If the patient has acidotic pH and a normal anion gap metabolic acidosis without clinical diarrhea, then renal tubular acidosis is likely that's what you are dealing with. What do we test? Urine anion gap, as I mentioned, sodium plus potassium, the positive one, minus chloride. If the number is negative number, patient is acidifying the urine normally, then there is no distal renal tubular acidosis. Simply think about, if you have so much negative, that means there is something I'm not measuring, which is positive. Then this is a hydrogen ion. And simply, this patient does not have distal RTA. For example, if your urine electrolytes reveals urine sodium minus is 40, urine potassium is 25, chloride is 100, then 65 minus 100 yields a negative number. Distal tubular is not present because the difference is, it's a negative charge. The difference is coming from the ammonium as hydrogen ion. We don't have a way to test the unmeasured ammonium. And there is a lot of tests that in clinical practice is not applicable. Therefore, we go to the back door to measure the urine electrolyte in a very simple way. It's not require any further testing. Any lab specified can help with that. Urine pH, if you guys remember, I mentioned about the threshold, whenever there is a threshold or not. However, it's less helpful than the urine anion gap. But remember that the distal part, which is type 1, those patients under any circumstances cannot acidify their urine properly. That's why their urine pH most of the time is above 5.5. However, patient with proximal, it can vary depending on their threshold. If they reach, before they reach the threshold, if they get the bicarb, you check their urine, the urine will be alkalotic. Now, they can acidify the urine very well. So that's why whenever I see an acidic urine, I know that I'm not dealing with distal RTA. I'm dealing with most likely proximal RTA in simple terms. If I'm seeing nephrocal stenosis, I think mainly of the distal RTA. It can be of confusing things. However, yet if I'm dealing with proximal tubule, if I give, or distal or type 4, if I give sodium bicarbonate or sodium citrate divided in 2 divided doses, 2 milliequivalent per kilogram per day, and I don't have, I'm corrected, then most likely I'm dealing with the distal part. And for patients with the type 4 require hydrogen restriction on their diet, and sometimes we need to give them diuretics or other medications, fludrocortisone, or to treat the hydrogen. Fludrocortisone is made to reverse the aldosterone, to stimulate the aldosterone response, so the patients will be able to excrete potassium. In the proximal part, type 2, higher doses and more often are really needed, and it's not going to be TID or BID. It's going to be at least 4 times a day for you to treat. So excessive higher doses, you're dealing with proximal, and you have to remember that the proximal, think about Fanconi, think about what causes Fanconi. Commonly, cystinosis. Cystinosis is a disease that affects the tubular transport of certain amino acids within the tubule. A defect genetically can cause this crystal, we call it cystine crystal deposition, resulting in a defect in the patient. These patients develop with marked acidosis, acidosis in those patients, and they end up sometimes developing chronic kidney disease. And for you to figure out those patients, you need to think about them from the beginning before they reach to that, because there is treatment for cystinosis that we can slow down the process of proximal tubuloinopathy and Fanconi syndrome. In summary, type 1 distal, and long time ago I stopped. I was confused, type 1, type 2. I start to think about it as, is it a distal, is it a proximal, and is it hyperkalemic type? The distal part is associated with hypocitrate. Citrate in the urine is less because you're having problem with the acid-base concentration balance at the level of the distal part of the nephron. Nephrocal stenosis can be a presentation and renal stones. Serum potassium could be normal and often low. Type 2, which is the proximal one, usually occur with Fanconi, phosphaturia, glucosuria, aminoaciduria, hypokalemia with metabolic alkalosis, and those acidosis. And those patients sometimes can be, and again, hypokalemia can be a presentation for these patients. And you have to treat their underlying cause or address their underlying cause of cystinosis to treat, to manage it. Type 4, associated with hyperkalemia and mechanism of the tubular responsiveness to aldosterone and the responsiveness to this aldosterone pathway, and it's associated with obstructive uropathy, especially in pediatrics and in older age with diabetes mellitus and diabetic nephropathy. I'm going to stop here. I have more to give on this topic, on telling you about exactly what happened at the tubules when they are dealing with these diseases. But with this, I will stop because I don't want to invade the other talks coming on board. And I would like to thank you all and happy to answer any questions you have. Are we going to ask questions now or later? What's the plan for that?
يعني إذا كان في burning question we can take a couple of questions بس عشان ما نتطرد. ما شاء الله دكتور بكري، يعني بصراحة it was very nice and was يعني سلسة جدا. Thank you very much والله. Thank you. It was very nice والله. محمد, are you spotting any questions؟ ما شاء الله الناس متفاعلة والعدد كبير لحد آخر لحظة. طيب في منو يا محمد في سؤال؟ أنا think ما خليت حاجة.
I don't see any question.
الكومنت كلها بليز كونتينيو. يعني هم كلهم عايزينك شوختهم للجزء الثاني، لكن يعني thank you very much.
Yeah, the next one is mainly the mechanisms of exactly what happens at the level of the tubular cells in each disease. And I just wanted to make it as broad as possible right now as a clinical presentation and when to think about it and how to approach it. If there's a need for the next one, I'm happy to do it at any other time, but I don't want to affect the schedule that we have. But it's a continuum of the topic, which is it's a Fanconi, and I will talk about Fanconi by itself and what happened in each disease that result in Fanconi. It's very interesting to just understand, to put it together on them.
احنا ناخذ وعد منك to organize another talk، يكون نخليك يوم كذا براك كذا ان شاء الله باذن الله مع الشباب. وان شاء الله يعني محمد بالله بليز يا محمد طبعا ما شاء الله منظم لنا الامور كلها، يعني ما شاء الله عليه.
ان شاء الله for sure ان شاء الله دكتور ابو بكر ان شاء الله we will invite you inshallah in a separate lecture to give us these important topics. أنا شايف كل attendees they are very enjoying much. They are thanking you so much. There is one question actually about nephrocal stenosis, either in type 1 and type 3 Barter. If there is nephrocal stenosis in all of them, this is just one question. I can spot it here.
So exactly. So we talk about Barter. and specifically the different type of Barters. If it is associated with hypercalciuria, and I do not want to get into the details about the types, if it's associated with hypercalciuria, then the answer is Nephrocal Stenosis will be present. For patients with distal RTA, the mechanism is a little bit different, which is because of the concern about the citrate concentration at the level of the distal part of the nephron, that when the reabsorption takes place, it's left with functional hypercalciuria, more or less, because the citrate is supposed to balance or chelate the calcium. So the end result is this in the distal part, stone formation and nephrocalcinosis. And a lot of times, nephrocalcinosis and stone formation. Yet, in certain types of proximal tubulopathy, it depends on where is the problem, you can develop nephrocalcinosis. So nephrocalcinosis is not absolute. For example, in certain diseases, we call it dent disease or Lowe's, those do end up having nephrocalcinosis as part of their, and they are proximal tubular, yes. And they have tubular dysfunction that's associated with proximal tubulopathy.
I think Dr. Rashid, if there is no other question, we can move to the next topic.
طيب I think حنواصل طوال افتكر يا حمد. شكرا جزيلا دكتور ابو بكر. ثانك يو فيري ماتش، والله وكتر خيرك كثير. ثانك يو فيري ماتش.
السلام عليكم.
عليكم السلام ورحمه الله وبركاته.
طبعا ما حبينا نقاطع، نحن مستمتعين جدا يا بروف ابو بكر امام هذه السياحه في التبيولوباثي. طبعا ده اصعب موضوع في النفرولوجي، عشان كده كل الجماعه بيتضايروا مني، لكن نعطي الخبز لخباز. يعني جزاك الله خير وشكر الله لك، ونسال الله ان يكون يعني فائده للجميع. احسنت، يعني ما قصرت كالعاده، دمهم متالق استاذنا الكبير. شكرا لك.
بارك الله فيك. بارك الله فيك. تسلم. شكرا لكم على الانفيتيشن.
الله يعافيك. لو قدمت لنا دكتور ابو بكر، قدمت لنا ياسر بخيت.
So it's my pleasure to introduce Dr. Yasser Bakhit. Yasser is, I came to know Yasser when I came to Sudan to visit and provide lectures down there as part of Sama days when we used to come there in December. And he always impressed me by his meticulous understanding of certain diseases. Yasser did his training in nephrology in South Africa. And in South Africa, we have a lot of people who are really eminent in nephrology, and it's a very well-recognized center. Yasser has done a great work in SOBA and in Sudan for the program of nephrology. Together with the rest of the group, Rashid, Mohammed Babikir, Prophet Tijani, the rest, Nahla, وبكل الشباب عشان ما ندخل في نسيان الناس. لكن Yasser has been great also in staying there, but finally he decided to jump the Red Sea, and right now he's in Saudi Arabia. Working with Muawiyah, Muawiyah was my previous fellow, and I'm pretty sure he will do a great job in the presentation today. تفضل دكتور ياسر.
شكرا دكتور ابو بكر. الله يبارك فيك. بعدك تاني الكلام بيصعب.
Dr. Yasser, you can share your screen.
Okay.
نقول ياسر منتدب الى السعوديه يعني.
لكن كده كلنا منتدبين يعني.
ياسر استعن بالله ولا تعجز، ربنا يعينك غايته. استعن بالله ولا تعجز، الكلام بعد امام صعب لكن ربنا يعينك انت لا ان شاء الله. يلا.
لكن ما اعرف عندي لي تكنيكال بروبلم كده.
في الزر الاخضر تحت الشير يا ياسر، دوز عليه.
هذا ضغطته.
طيب يلا بيقوم بيجيك فوق على يدك اليسار فوق بديك اخر برزنتيشن مفتوح كان في الحاجه اللي بتفتح لك.
ما في اخر برزنتيشن.
نحن we can see your screen يا دكتور ياسر حاليا.
انا شايفكم برضه.
افتكر ممكن تعمل دوكيمنت ريكفري.
طيب كده
دوكيمنت ريكفري من الليفت سايد.
شير
على يدك الشمال ايوه انتايتل. انت عامل شيرنج كويس بس افتح الشيرنج. افتح شيء على يدك اليسار مش على اليسار.
شو ما صارت يا جماعه.
كده ممكن تعمل انشير وشير ثاني.
طيب شير
يعني ستوب الشير وبعدين ثاني يو بريس ات اجين. ايوه
ستوب الشير.
ايوه كده. ونحن شفنا سلايد قبل شويه. كده الشير ستوب. يو كان شير ناو. ايوه
كده شير ولا
ظاهر سلايد على البروجنوزس. سلايد نمبر 5.
ايوه
عمل ماكسمايز.
تمام. اوكي
طيب كده
we can see السلايد اللي فيها ايوه definition prognosis the aim. ايوه تمام. اوكي you can start.
طيب بسم الله الرحمن الرحيم. شكرا دكتور ابو بكر على المقدمه، وشكرا على محمد زين وراشد على التنسيق، وشكرا للشباب. يعني ان شاء الله يعني الواحد يقدر يساعدهم بحاجه. Today we'll talk about the prevention of progression and treatment of chronic kidney disease in children. طبعا هو موضوع شويه يعني بعد ابو بكر يبقى صعب، لكن اهو. طيب chronic kidney disease طبعا يا جماعه زي ما عارفين هي international public health problem affecting 5 to 10% of world population. The prevalence of pediatric chronic kidney disease range from the 15 to 75 cases per million children. Mortality among the children who progress to end-stage renal disease is 30 to 50 times higher compared to that in the general population. In Sudan, it is a common disease. Estimated incidence for few cases is about 70 to 140 per million per year. Incidence rate for pediatric end-stage renal disease is 14 per million children under the age of 19 years. The renal patient represent 32% of the total hospital children admission. There is a higher mortality rate among the children of the renal problem is due to delay diagnosis, lack of facility, and awareness. The definition is characterized by irreversible deterioration of the renal function that gradually progress to end-stage renal disease. طبعا ده old definition, و current statistic after this definition, the 70% of the children with chronic kidney disease develop end-stage renal disease by 20 years of age. Children with end-stage have a 10 year survival rate of about 80%. فكوديكو and National Kidney Foundation يعني it is a group. كوديكو is a kidney disease outcome quantity initiation والنايس كدني فاونديشن فوضعوا criteria to reduce the mortality and morbidity of the chronic kidney disease. فكانت definition is wide definition is defined as evidence of structural or functional abnormality of the kidney that persists for 3 months or more, with or without decrease in the GFR. Well, indicator of one or more abnormality as follow is in the urine. There is a detect proteinuria or hematuria or cast. In the blood, you can detect the anemia or the mild increase in the creatinine or high uric acid. In the imaging, in the ultrasound, can detect single kidney or polycystic kidney disease with normal renal profile, or to detect the posterior visceral valve histopathological to detect the focal segmental glomerulosclerosis. The other definition, GFR less than 60 ml per minute per surface area for 3 months or more. While this definition is not applicable for children under younger than 2 years because still the kidney is immature. So the aim for this definition to develop clinical practice for prevention, early diagnosis, and optimal management of childhood onset chronic kidney disease to reduce the mortality and morbidity of chronic kidney disease. The classification, according to the CODICO guideline, it is put it according to the GFR and structural or functional abnormality. So stage 1, there is a kidney damage, but with normal or increased GFR. And the other stage, there is decrease in the GFR from stage 2 to 5. The etiology of chronic kidney disease, the main causes of chronic kidney disease in children, it is obstructive uropathy. And hypoplastic or dysplastic kidney disease reflects nephropathy and focal segmental glomerulosclerosis. And autosomal recessive or dominant polycystic kidney disease. This is widely data, but in Sudan, the main cause is glomerulopathy is 25%, 27% of total data. This data collected by Muhammad Babikir and Prophet Tijani and Rashid. And the congenital urological malformation is 19.2, still high, and unknown is 28%, still high, unknown causes. The risk factor of chronic kidney disease, usually the base weight. The low base weight have a high risk factor to develop chronic kidney disease. The number of the nephron, the genetic factor, or there is some diseases, is genetic disease can cause chronic kidney disease, and found some genome in the in children can develop at the end of the chronic kidney disease. Ethnic, it found that the black people, black children or African children is better than the black children. The African children is the high risk factor to develop chronic kidney disease because they have a focal segmental age. Usually, the chronic kidney disease common in after the 6 years of age, and also the others factor like proteinuria, hypertension, obesity, dyslipidemia, mineral hemostasis, and hyperuricemia. All of these is the risk factor can cause chronic kidney disease. So when we recover patient with these factors, can develop chronic kidney failure, the GFR become less than 60. The primary disease can, if it is observed well, can recover or can develop chronic kidney disease. The chronic kidney disease can be regress or progress to end-stage renal disease and can be cause the death by the cardiovascular complication. There is a lot of cellular pathway and molecular pathway can cause at the end of nephron loss and interstitial fibrosis. So the pathophysiology of the chronic kidney disease, whatever the cause or the risk factors to reduce the number of the nephron, like immunological insult or vascular insult or dysplastic or autoimmune, whatever the cause, like Rashid mentioned in his topic, there is a lot of acute kidney injury can cause chronic, at the end can develop to chronic kidney disease. So when there is a initiation factor that can reduce the number of nephron, when the nephron is less than 50 of the total numbers, the pathway is the same, and all of them, the pathogenesis is the same. So when it's reduced less than 50, there is activation of the vasoactive mediators and cytokine and renin, angiotensin, aldosterone system, and growth factor, which lead to structural and functional change of the survival nephron and can cause systemic hypertension also. So when the load on the survival nephron, there is a mechanism is called adaptive glomerular hyperfiltration. The nephron is become hyper or compensate to the other nephron and become overactive and hyperinflation, inflation, so can cause proteinuria and increase GFR in this stage. So when the nephron become hyperactive and compensate, so increase the intraglomerular capillary pressure and cause glomerular hypertension, and this with the inflammatory mediator accelerate the sclerosis of the ramin nephron. And so the nephron is losses here, and the cycle is continue and can cause the progression of the chronic kidney disease from stage 1 to 2 to end stage renal disease by this mechanism. The other pathogenesis in chronic kidney disease is hypertension. As you know, the hypertension is the main cause of the chronic kidney disease. And chronic kidney disease can cause hypertension at the same time. So the mechanism of hypertension or pathophysiology of hypertension in chronic kidney disease mainly by activation of the renin angiotensin aldosterone system, which secreted the renin in the kidney and act on the angiotensin gene from the liver to angiotensin 1 and angiotensin converting enzyme from the lung acting on the angiotensin 1 and the result is angiotensin 2. Angiotensin 2 activate or stimulate the aldosterone. At the same time, angiotensin 1, which is a vasoconstricted and cause hypertension, and also is the salt and water and can cause salt and water retention and cause also hypertension. And aldosterone also from the adrenal cortex cause salt and water retention and cause hypertension. The other mechanism is sympathetic nervous system, also can cause hypertension and impair vasomediators and reduce nitric oxides in endothelial mediators. It is the vasodilator mediator and also can cause hypertension. The other mechanism is increase the calcium in secondary hyperparathyroidism and cause vascular smooth muscle contraction and cause hypertension. The other pathophysiology in chronic kidney disease is mineral bone disease. So when the kidney is fail or decline, reduce the GFR. When the GFR is reducing, reduce the urine phosphate secretion, and this is stimulates the fibroblast growth factor 23, which increase and stimulated to increase the phosphorus secretion. But unfortunately, here the kidney is unfunctioning. So it is inhibit the alpha-1 hydroxylase to reduce the active form of vitamin D, cholecalciferol, and reduce the intestinal calcium absorption in the gut. And this is increase the parathyroid hormone, so can cause secondary hyperparathyroidism. So, consequent of the secondary, when we develop secondary hyperparathyroidism, can cause vascular calcification, increase the morbidity from the cardiovascular disease, can cause renal osteodystrophy, and may present as osteomalacia, osteitis fibrosa, increase here the turnover of the bone, and mixed uremic bone disease, osteomalacia and osteitis fibrosa, and adynamic bone disease. This is result from the heterogenic of the therapeutic over suppressed parathyroid hormone. The other pathophysiology in the kidney disease is the anemia. The main cause of the anemia is reduced production of the erythropoietin. And when they reduce the production of the erythropoietin, suppress the bone marrow and reduce the production of the RBCs and cause anemia. There is another causes like iron deficiency due to anorexia and loss of appetite and decrease the absorption of the iron in the gut. Also increase the red cells turnover and half-life becomes 70 days. And there is also accumulation of the ammonia and cause toxicity and suppress the bone marrow. Malnutrition from the anorexia and from the severity of the disease cause also anemia, and bone marrow suppression by the acidosis and uremia, and chronic inflammatory process also can cause anemia by suppression of the bone marrow. So this is the mechanism of chronic kidney disease. So how to biomarker the chronic kidney disease, or how to detect the chronic kidney disease? So the level of blood urea and creatinine does not correlate with the development of chronic kidney disease symptoms. Estimated GFR seem to be associated with a strong correlation. So the clinical presentation in stage 1 and 2 usually asymptomatic. Just find abnormality in the urine and high blood pressure, mild or moderate high blood pressures, and sometimes the child come with polydipsia and nocturia. In stage 3 and 4, stage 3 up to 5, usually there is a symptoms like volume overload, hyperkalemia, metabolic acidosis, hypertension, anemia, bone disease, osteodystrophy, or cardiovascular disease, anorexia, and nausea and vomiting. The main physical finding in chronic kidney disease is anemia. Usually the patient look pale and short stature and hypertensive. There is a sign of osteodystrophy. There is a cardiac abnormality like left ventricular hypertrophy or pericarditis from the uremic pericarditis. And we can hear the pericardial rub. Peripheral neuropathy. There is CNS abnormality, loss of consciousness, lethargy, seizure or coma, and there is some dermatological manifestation. So marker of the chronic of the kidney damage, usually from the history and examination and from the urine examination by deep stick or microscopy. The deep stick is quick method for screening and can detect proteinuria, hematuria, and polyuria, and estimated specific gravity. Other marker, urine microscopy to look for the RBCs in the urine, mainly the indicate of the IgA nephropathy or other glomerular disease, or white blood cells, or cast. Usually in chronic kidney disease, we found the hyaline cast. And modeling bronch granular cast and epithelial cast suggests acute tubular necrosis, and RBCs suggest acute nephritis. Usually we do spot urine for protein to creatinine ratio. If it is nephrotic range or it is significant, this is glomerulopathy usually, and microalbuminuria suggests the diabetic nephropathy. Other biomarkers, the blood, serum creatinine usually elevated, and blood urea nitrate also elevated, hypoalbuminemia, hyperuricemia, and other findings common in the chronic kidney disease like anemia, present in 90% of the patient with GFR less than 30. Hyperkalemia, metabolic acidosis, and secondary hyperparathyroidism, increase the phosphorus and parathyroid and reduce the serum calcium. The imaging is important as a marker to detect the chronic kidney disease. The main imaging is renal ultrasonography. It is a safe and informative and can detect anything in the kidney, increase the echogenicity or small hyperechogenic kidney, and absent or one kidney. And kidney scarring is difficult by ultrasound, but it needs some expertise to use it. Hydronephrosis, renal artery stenosis, acute nephritis, and others. Radionuclear study to detect the renal scarring by the DMSA, avoiding cystohysterogram, also to detect vascular reflex, and renal biopsy for histological features. الصورة هنا مو واضحة. دوري راشد الصورة ما واضحة. طيب other biomarker يعني usually the creatinine and proteinuria is the lead biomarker in the course of kidney damage. So there is a new biomarker can be used, a novel biomarker, to identify the child with earliest stage of injury and repair. Usually use the urine neutrophil gelatinase associated lipokylin It is not improved clinically, but in the lab it's used. And tumor necrosis factor receptors 1 and tumor necrosis factor receptor 2 is a strong biomarker with progression to end-stage renal disease. Biomarker of kidney disease also to estimate the glomerular filtration rate is the best overall indicator of the level of the kidney function. The normal GFR variety with the age, gender, and body site much lower in infant because the kidney is not mature enough. Adjusted adult values of GFR by 2 years of age, the Schwann and Cohen-Barth equation are the most common used in the children. Usually, Schwann is formula is dependent on the height and plasma creatinine and constants. So the GFR calculated by the 0.41 per hair per centimeter per plasma over plasma creatinine per milligram per deciliter. Still, there is some center use the equation depend on the different age. So the constant, it is the different, it is the differ from among the different age. The other biomarker to calculate the GFR is the plasma cystatin C concentration. It is produced by all nucleated cells, and a rate of the production is constant. So it is more sensitive than the serum creatinine. Unaltered by the inflammatory condition or change in diet, more accurate than plasma creatinine. Genetic of the kidney disease, also there is the kidney disease is a heterogeneous disease, and various studies have shown high kidney disease The genome is wide associated study, identify راشد انت سامعني؟ The genome-wide associated study identify several genetic loci, include the UMOD and SHROOM3 and solid carriers and E3. So the genetic is important to detect the chronic kidney disease. Differential diagnosis can can put acute kidney injury because both of them can be presented with the deterioration of the kidney function. But usually in chronic kidney disease, there is short stature, there's anemia. And usually when we take a proper history, we can differentiate acute kidney injury. Also the chronic glomerulonephritis, it is another differential diagnosis of chronic kidney disease and rapid progressive glomerulonephritis. So be careful in the history and the clinical examination. Usually the chronic kidney disease is coming with short stature, anemia, and bone disease, and cardiovascular problem. Usually it's present with complication. So the management, it is a multidisciplinary team for management of chronic kidney disease. Combine play therapist community nurse, radiologist nurse, dietitian doctors, surgeon. Everyone can share in, even the society can share in the management of chronic kidney disease. طيب the management can be reversed the chronic kidney disease. طبعا دي impossible. This is dreamed. It is not available yet. This is option. Can be intervened with chronic kidney disease in early stages to reduce the progression and to prevent the chronic kidney disease stage 5. The goal of management of chronic kidney disease to treat the primary cause for kidney impairment, minimize associated comorbid state, and prevent the loss of the kidney function, treat the metabolic disturbance associated with chronic kidney disease, prevent and treat cardiovascular disease, optimize normal growth and development. Treatment of chronic kidney disease should include specific therapy based on the diagnosis, evaluation and management of comorbid condition, slowing the loss of the kidney function, prevention and treatment of the cardiovascular disease, prevention and treatment of the complication related to decreased kidney function like hypertension, anemia, acidosis, growth failure. So how to prevent the progression of the kidney disease? By controlling the blood pressures and management of proteinuria. Right. Management of the hypertension, as mentioned before, it is due to activation of the renin-angiotensin system. So we use antihypertensive AC inhibitor or salt and water. If there is salt or water retention, we can use loop diuretics. If there is activation of the sympathetic nervous system, usually we use beta blockers. So the antihypertensive is depend on the underlying cause of the hypertension. When we start the AC inhibitor, usually we measure the blood pressure. This is the important, measure the creatinine and potassium before and after 2 weeks of starting. To prevent the progression also to lowering the salt intake, we usually يكون less than 2 grams per day of the sodium, corresponding to 5 grams of the sodium chloride, unless contraindication. يعني مرات chronic kidney disease there is a type of polyuric type of chronic kidney disease. ففي البوليوريك تايب دائما ما بنعمل stricture للسولت. The structure of the salt intake for children with chronic kidney disease have hypertension following the 8 base, free water and sodium supplement for the children with chronic kidney disease and polyuria to avoid chronic intravascular depletion and to promote optimal growth. Polyuric child with chronic kidney disease are at a risk of volume overload and hyperkalemia, require dietary restriction. يعني دائما الاوليجيوريك تايب of chronic kidney disease انت بتعمل لهم require يعني dietary، تعمل لهم dietary restriction للفلويد والصوديوم and potassium. To prevent also the progression of chronic kidney disease, treat the anemia. So the beneficial effect of the treatment of the anemia in chronic kidney disease to improve of the cardiac status, exercise capacity, and cognitive function, and improve quality of life. So we use, as we mentioned before, the main cause of the chronic kidney of the anemia in chronic kidney disease is the erythropoietin deficiency. So we use human hormone erythropoietin therapy and iron supplementation. فالريكورمون دائما بيتاخذ يعني يا سبكتينيوس يا انترافينوس يا انترابروتينيال. والانيشيشن دوز هي 300 unit per kg divided into the 3 separated doses. maintenance dose of EPO is 60 to 600 units per kg per week. Diamond ongoing blood loss and infection or inflammation, secondary hyperparathyroidism and iron deficiency induce EPO resistant. يعني دي الحاجات اللي بتخلي الإريثروبويتين unactive. The target hemoglobin is 11 to 12 gram per deciliter. Hematocrit between the 33 to 36%. This is recommended by the Codico. When we use the iron therapy, لأنه إذا كان في iron deficiency anemia, the erythropoietin is not active. So we give iron supplementation. Usually the target of the iron, it is the saturation is more than 20%. If it's less than 20%, you can give iron IV. Usually it's better than the oral. Also, to prevent the progression, treat the mineral bone disease, change in the bone mineral metabolism, and alternation in the calcium and phosphate. Hemostasis occur early in the course of chronic kidney disease and progress as the kidney function decline. Nutritional instruction for limiting dietary phosphate intake, to give a phosphate binders, وهم two type الفوسفات بايندر يا calcium based phosphate binder ودي دائما increase the risk of the vascular calcification. And recent non-calcium based phosphate binder have been used in control hyperparathyroidism, hyperphosphatemia, and hyperparathyroidism without cause hypercalcemia. Also use vitamin D active form, cholecalciferol, should be used to treat hyperparathyroidism. So how will change the clinical practice? We will get used to estimated GFR for renal function. Hypertension and proteinuria are the most important independent risk factor for renal diseases progression. The national specific guideline for management of chronic kidney disease is ineffective. You must consider renal disease to be, you must consider renal disease and to be common. You will get used to estimated GFR. The risk, the hyperalbuminemia, usually this is if it is not treated, this condition can lead to the reduce the GFR. Here, hypoalbuminemia and hypertension, dyslipidemia and male gender, they're high risk to develop chronic kidney disease and anemia to progress renal chronic kidney disease, anemia, nephrotic range proteinuria, dyslipidemia, and hyperphosphatemia. However, the rate of the progression depends on the underlying diagnosis or underlying cause or primary cause of chronic kidney disease. Usually, if the glomerular disease is most common disease and it is very aggressive disease and can cause chronic kidney disease. شكرا جزيلا.
شكرا ياسر ما قصرت. Good presentation, excellent one. Thanks for the contribution. استمتعنا جدا، جزاك الله خير.
الله يديك العافية.
Very tough topic. Very tough topic to cover, ya Yasir. But I've always tried to tell people that when we deal with chronic kidney disease, look at all parameters from acidosis, anemia, growth failure, bone disease, and nutrition. So in children, it's even more complicated by other factors that sometimes you have to use certain medications that have significant side effects, and some of the medications are not even approved in children. Very nice presentation, very nice discussion. Thank you.
Hamazin, any question or?
طيب شكرا دكتور ياسر. and I will try to look in the questions. طيب we have one question. Why RBC lifespan is reduced in chronic kidney disease?
Yeah, usually the RBCs يعني بيكون عندها high turnover or reduce the half life because the usually يعني from the uremia and metabolic acidosis, so the half life is reduced usually.
Okay. We have second question. How does chronic kidney disease causes cardiovascular disease?
The chronic kidney disease يعني usually can cause يعني من overloaded and from the uremia can cause the left ventricular hypertrophy. Some people بيقول لك accumulation of the cystine. So sometimes we use the folic acid to reduce the accumulation of the cystine. So there is a multifactorial can cause a cardiovascular disease. The first one هي overloaded والhypertension. All of these can cause anemia itself can cause cardiovascular and mineral bone disease. The calcification of the vessels, the select deposition of the calcium in the wall of the vessels and can cause hypertension and can cause heart diseases.
Okay. Other question. There is one question. There is one question here about when patient do we do dialysis only when patient progress to stage 5?
ما فهمت سؤالك. يعني دائما الدياليسيس at the stage 5.
I think he is asking about at what stage, at what time we start the dialysis.
Yes. There is طبعا indication of the dialysis at general. In the chronic kidney disease, if the patient is asymptomatic, but the GFR is less than 6, is indication for hemodialysis or for dialysis, whatever it is, يعني, the modality. And there is a other absolute indication for dialysis. This is the hyperkalemia with ECG change. طبعا ما بتنتظر الميديكال تريتمنت. The absolute indication. يعني hyperkalemia with ECG change and يعني anuria. يعني there is anuria. This is absolute indication. And يعني في uremic symptoms like CNS manifestation or GIT manifestation. This is absolute indication of the dialysis. There is another indication of the dialysis if there is the other parameter like acidosis, hyperkalemia, hyperphosphatemia, hypertension, but not response to medical treatment. فدي indication. لكن دائما في الكرونيك كدني ديزيز وخاصه في البليوريك تايب يعني the patient is compensate. يعني مرات تلقى الجي اف ار بتاعه less than 5 وهو ما محتاج دياليسيس. فبتلقاه sometimes is compensated. فدي الانديكيشن اوف ذا دياليسيس. طبعا الدياليسيس ذاته there is a modality of the dialysis. The better modality is the peritoneal dialysis. وكنا في السودان زمان يعني بنجبر العيانين يعملوا البروتينيه الاول، بعدين ندخلهم يا محمدين لو بتتذكر ندخلهم الهيمودياليسيس. لكن هسه بقت هي تشويزبل، يعني انت بتدي التو موداليتي وبتدي الكومبليكيشن وبتدي الادفانتج والديس ادفانتج، وتخلي الفاميلي او البيرنتس تشويز ذا بيتر يعني موداليتي فور هيم. هسه بقت يعني هنا البيتر تريتمنت اوف كرونيك كدني ديزيز، وده ما تكلمنا عنه خاصه في الاند ستيج، هي الترانسبلانتيشن. والناس هسه بيتكلموا عن البريمتيف ترانسبلانت، يعني حتى يكون ما في انديكيشن لدياليسيس ولا كده، لكن دائما في ستيج 4 او في الانيشال ستيج 5 كان دو ترانسبلانت بيفور تو ستارت الهيمودياليسيس which is better treatment، لانه دائما الكرونيك كدني ديزيز is difficult to control خاصه في الكلدري. يعني to replace الكالسيوم البون المينرال بون، to replace الانيميا الاسيدوزيس، يعني هي يعني to cover all the function by the medical treatment is very difficult. So the better is to transplant especially in stage 4 يعني preemptive او في stage 5 في end stage renal disease.
Yes.
طيب محمد افتكر we have to move للسكند توك يا محمد.
Okay.
ياسر والله it was really nice والله, it was very very nice, very useful والله, شكرا جزيلا والله, thank you, it was very nice ما شاء الله, very organized, السلايدز very well prepared ما شاء الله, everything was perfect يعني والله, جزاك الله خير يا اخي, thank you very much والله. And I think we have to move as scheduled. عندنا the last talk وختامه مسك, يعني احنا اول حاجه سعيدين جدا جدا انه as a group of as a family of pediatric nephrologists وعددنا القليل ده انه مثلنا دره يعني definitely يعني للجروب بتاع pediatric nephrologists السودانيين. دكتوره نسرين سماده. نسرين يعني خريجه بتاعت جامعه الخرطوم, very motivated. She did her pediatric nephrology training at South Africa. She was trained in a center in South Africa. She opted herself after getting the certificate أخذت تاني another attachment time في major center تاني عشان تاخد زيادة experience. يعني كل اللي قابلناهم هناك بيتكلموا عن يعني how she excellent she was يعني هناك. فيعني وإحنا نسرين عارفين أصلا من الأول she is يعني one of the best بصراحة. very enthusiastic, very motivated. نسرين شكرا جزيلا, يعني إضافة كبيرة لنا, وإحنا سعيدين جدا بأنك تقدمي لنا, وإن شاء الله تكون بداية ومستمرة إن شاء الله. دكتور نسرين هتقدم hypertension. the floor is yours دكتور نسرين, تفضلي.
Thanks for a nice introduction, Dr. Rashid. I will try to. I share. Sorry.
We can see your desktop يا دكتور نسرين. مرحبا.
Okay. You know, it's okay.
أيوة, yes, it's open now. أيوة,
Okay.
you can make it. أيوة, full screen. Okay, you can start.
Okay. Thanks for nice introduction, Dr. Rashid. Good evening, everyone. And today we cover hypertension overview in pediatrics. You know that it is a big topic, but I will try to make it simple and try to to highlight the important things. And we end our lecture by clinical scenarios, and we hope that it will be an interactive session. Our objective, the definition and classification of hypertension, when to measure blood pressure, definition of hypertension, emergency and urgency, by age, when to start treatment, evaluation, and then at the end we end with 6 clinical scenarios if time allowed. The definition, hypertension is based on cardiovascular morbidity and mortality in adults. And in children, it is based on the normal distribution of blood pressure in healthy children, not based on cardiovascular morbidity and mortality. And hypertension is defined by average systolic blood pressure and diastolic blood pressure that is 95th percentile or more for age, sex, and height on 3 or more occasions. This is the definition of fourth report in 2004. The normal blood pressure is systolic or diastolic blood pressure below the 90th percentile, and the pre-hypertension is from the 90th percentile, but below the 95th percentile, and stage 1 hypertension is systolic or diastolic blood pressure equal to the 95th percentile, but lower than the 99th percentile plus 5. And stage 2 hypertension, it is equal or higher than the 99th percentile plus 5 millimeter. This is the classification for the European Society Hypertension Guideline in 2016. They defined the patient by the age from 0 to 15 and 16 or higher. So the hypertension, as we said, it is more than or equal to the 95th percentile, and stage 2 and stage 1 and stage 2 hypertension, as we said. But in 16 years or older, the hypertension is defined if the blood pressure is 140 over 90 or more. This is the table of the centile chart for the age, height, and sex, according to the height and the age. And this is the update of blood pressure categories and stage according to the American Academy Pediatric Subcommittee. And they define the blood pressure definition from 1 year to less than 13 years or from children 13 years or above. So the normal blood pressure is less than the 90th percentile, elevated blood pressure 90th percentile or more, to less than the 95th percentile, and stage 1 more than the 95th percentile or 95th percentile, less than 95th percentile plus 12 millimeter Weber. So we see here there is no 99th percentile in the update definition. And stage 2 hypertension, it is 95th percentile plus 12 millimeter or plus 12 millimeter or equal to 95th percentile plus 12 millimeter. For children aged 13 years or more, stage 2 hypertension is the blood pressure 140 over 90 or more. And we see here, there is the difference that we didn't find the pre-hypertension. If it is in this category, so it is elevated blood pressure. There is no pre-hypertension in the update guideline. And this is the blood pressure for the children according to the age, according to the American Academy of Pediatric Subcommittee. And we noticed that the cutoff of the blood pressure is lower than the previous fourth report of hypertension in 2004. This how to measure the blood pressure. We determining the proper cuff size by the patient arm size. We need that the bladder, the cuff of the bladder width should be 40% of the circumference of the arm measured at the mid-arm, and the length should be 80 to 100% of the circumference of the arm. So the most important thing is the proper cuff size to measure the blood pressure, because the smaller cuff size will give you high blood pressure. When to measure blood pressure, all children more than 3 years of age should measure the blood pressure in the casualty or at any presentation to the emergency or to the clinic, or less than 3 years of age. Under special circumstances, we should measure the blood pressure like premature infant, low birth weight, congenital heart disease, recurrent UTI, hematuria or proteinuria, renal or urological disease, systemic disease like neurofibromatosis or systemic lupus erythematosus, solid organ or bone marrow transplantation, and drug which increase blood pressure like corticosteroid, tacrolimus, and cyclosporine. Definition of hypertension emergency and urgency. Hypertensive emergency is severely elevated blood pressure. We mean by severely elevated blood pressure stage 2 hypertension with evidence of target organ damage, and most commonly the CNS, the kidney, the cardiovascular, and the eye involvement. hypertensive urgency is severely elevated blood pressure with no evidence of end organ damage, but if left untreated, will end by target organ injury. This is the end organ damage for the hypertension. You see here, affect the heart by left ventricular hypertrophy and congestive cardiac failure, the brain by hemorrhage and CVA, retinopathy in the eye, peripheral vascular disease, and affect the kidney by renal disease and proteinuria. As I said, severe hypertension is defined as stage 2 hypertension is usually associated with secondary hypertension, while primary hypertension is associated with mild or stage 1 hypertension. Symptom and signs suggestive of underlying disorder indicate secondary hypertension, so we should search for the cause from history examination and investigation to do the investigation point to the suggestive disease from the history. Primary hypertension is associated with overweight and or positive family history of hypertension. Regarding the etiology by age, less than 14 years, it is mostly secondary, it's 98%, and essential hypertension is very minimal, it's 2%, and more than 14 years, essential is 75%, and the remaining is secondary. Etiology by age, according to the age group, the common cause in newborn, renal artery thrombosis and embolus. We should ask about umbilical artery sterilization during neonatal period, renal vein thrombosis, congenital renal malformation, coarctation of the aorta. So we should measure the falling blood pressure, renal artery stenosis, and bronchopulmonary dysplasia. In infancy to 6 years, the most common cause is renal parenchymal disease, renal artery stenosis, coarctation, and we should go through the medications of the child taken, the corticosteroid or albuterol, and endocrine causes. From 6 to 10 years, renal parenchymal disease, renal artery stenosis, essential hypertension, and endocrine causes. In adolescents, the most common cause is primary or essential hypertension, especially in our era now that obesity is common and white cause, and so you should measure the blood pressure, and then you can do the automated blood pressure measurement, and renal parenchymal disease and substance abuse like cocaine, amphetamine, and caffeine, and endocrine causes. Also, you can define etiology of hypertension by the system involved secondary to the cause, like renal, glomerulonephritis, reflex nephropathy, obstructive neuropathy, and in cardiovascular, like aortic coarctation, fibromyalgia, Wilms tumors, like malignancy, endocrine Cushing syndrome, and as I said, the drugs. I will not go through all this. Okay, so when to start treatment? You should start treatment in stage 2 hypertension, symptomatic hypertension, secondary hypertension, hypertension with target organ damage, as we said, diabetes type 1 or type 2, resistant hypertension despite non-pharmacological measures. And we mean by non-pharmacological measures like DASH diet, which is dietary approach to stop hypertension. It is fresh fruits, fresh vegetables, and low salt diet, exercise, and all these things. If this measures is not drop the blood pressure, especially in stage 1 hypertension, then you can start treatment. But in stage 2 hypertension, you directly start treatment. Antihypertensive medication, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, calcium channel blocker, diuretics, loop diuretics, iodide diuretics, and potassium sparing diuretics, beta blocker, central alpha antagonist, clonidine and methyl dopa, and peripheral alpha antagonist, prazosin, and vasodilators. This is the medication with the dose and the maximum dose and the contraindication and the indication. So you should go through all this. Whenever you prescribe any treatment for the patient, you should go know the indications, the contraindication, and the side effect. But you should know that when you start angiotensin converting enzyme inhibitors or angiotensin receptor blocker, as Dr. Yasser said, you should follow the serum chemistry, the renal function test, and the potassium 2 weeks after. And it is contraindicated in patients with bilateral renal artery stenosis or renal artery stenosis in single kidney. Evaluation. So our evaluation will start from the history. As we know, the history is the cornerstone of any treatment in our patient. So history, then the physical examination. First, you want to know, is this patient hypertensive or not? So you need proper cuff sign, repeated measurement. It will be 3 occasions. 3 occasions in different time. If you concern about white coat hypertension or mask hypertension, you should do ambulatory blood pressure measurement. Also, you should ask yourself about target organ damage to know it is urgency or emergency hypertension, because the management will be different. And you need to drop the blood pressure gently in the emergency hypertension. And you need to start intravenous infusion. Also, associated cardiovascular risk factor, diabetes, elevated lipid, and cardiac disease, and you know to search about the cause. Why we want to search about the cause? Because there is like a specific treatment for the cause. Then when you know the cause, you know the mechanism of hypertension, then you will choose the appropriate antihypertensive drug. Symptoms of hypertension, neurological signs and symptoms like headache, visual disturbance or vertigo. They can present with heart failure. They can present with subtle symptoms like tiredness, developmental delay, decline in school performance, growth retardation, or epistaxis. Clinical history, so you should go to the history of secondary hypertension. You ask from the prenatal history, oligohydramnios, anopsia, umbilical artery catheterization, renal artery or vein thrombosis, or also you ask about underlying or concurrent disease like renal, urological disease, trauma, repeated UTI or recurrent UTI, edema, weight loss, failure to thrive, thirst, polyuria, nocturia, hematuria. Then also you ask about cardiac, endocrine, neurological, or cold extremities, intermittent claudication, palpitation, sweating, fever, and pallor, and flushing. And you also see the systemic disease like lupus erythematosus. You ask about any drugs. And as we said, history or symptoms of target organ damage like headache, epistaxis, vertigo, visual impairment, facial palsy can be the presentation of high blood pressure. So any patient present with facial palsy, you should measure the blood pressure. Seizure, also any patient present with seizure, you should measure the blood pressure. Stroke, low school performance, dyspnea, chest pain, and palpitation, and syncope. Clues towards renal disease can be edema, polyuria, nocturia, hematuria, fatigue, muscle weakness, failure to thrive, history of oligohydramnios, and family history of renal disease. Also, renovascular disease, you should ask about, as I said, umbilical artery catheter, neonatal asphyxia, episode of severe hypotension, and tumor, you should ask about weight loss, flushing, and sweating. And don't forget the skin abnormalities in systemic lupus erythematosus, neurofibromatosis, and scleroderma, and family history such as hyperthyroidism. Also, the clues of essential hypertension, like the weight gain, diet, smoking in teenagers, and family history of cardiovascular disease, and sleep disturbance, like sleep apnea. Important question at follow-up visit, you should know about the medication side effects, such as fatigue in the beta blocker, angiotensin converting enzyme inhibitors, and uresis in diuretics. Compliance, also you should ask about compliance with therapeutic lifestyle change, and compliance with medication. Examination, you should examine the patient from head to toe. You should examine the patient thoroughly. I will not go through all this, but don't forget the skin examination in hypertensive child. So we reach the clinical scenarios. We try to make it an interactive session. And okay, we go to, now we reach case 1. So 9-year-old girl was admitted to hospital with history of gross hematuria, edema, history of sore throat 2 weeks previously, generalized edema, he's not distressed, and the blood pressure is 160/120, other vitals normal, and no ascites. So Anyone can be volunteer. You hear me? Okay. You can write your thought in the chat box.
Nisreen, we can hear you.
Okay. Okay, you can write yourself in chat box. Okay, so this is 9 years. The blood pressure is 160/120. So it is very high. It is more than 140/90. So it is stage 2 hypertension. So we need to define the high blood pressure. So he had stage 2 hypertension. Second things, we need to know if there is any signs or symptoms of target organ damage. There is no sign or symptoms of target organ damage. So this is hypertension because it is stage 2. This is hypertension urgency. It is not an emergency. Third things, we want to know that it is primary or secondary. So from the history, it looks like secondary because we have clues in the history and examination. So we have a child with gross hematuria, edema, and history of sore throat 2 weeks previously, and he's edematous. And we can ask about the urine amount. We can ask the mother about the urine amount. It will be oliguric. And then we can ask about detailed history about this gross hematuria. So what is your thought and how you manage this patient? Anyone want to volunteer? Okay, so this is stage 2 hypertension, hypertensive urgency, not emergency. So this hypertensive urgency, so we can start oral antihypertension because it is not hypertensive emergency. And at the same time, we can work up the patient. So we did the urine dipstick. The color is reddish. The blood is 4+. There is granular class 2+ with 3+ protein. We did the urine protein creatinine ratio. It is non-nephrotic brain proteinuria. SO titer is high. Anti-double-stranded DNA is negative. Serum creatinine is normal, and the urea is normal, and the electrolyte is normal. C3 is low, and C4 is normal, and ANA is negative. So what is your diagnosis? Okay, so this is acute post-streptococcal glomerulonephritis. Okay, how you manage the acute post-streptococcal glomerulonephritis? The acute post-streptococcal glomerulonephritis, the hypertension primarily is due to sodium retention. It is leading to fluid overload as evidenced by suppression of the renin, angiotensin, aldosterone system. There is no specific treatment for the disorder. Treatment is focused on relieving symptoms, and the major goal is to control edema and the blood pressure. And we need, during the acute phase of the disease, to restrict the salt and water. And if significant edema and hypertension develop, we administer loop diuretics. If the patient is still hypertensive and we need to add the second line choice is calcium channel blockers, and ACE inhibitors and ARB carry the risk of hyperkalemia and temporarily impair the recovery of kidney function. So it is not the good choice in patient with acute post-streptococcal glomerulonephritis. We move to case 2. In any case, we need to do the same thing, like define the hypertension. Then is it hypertension stage 1 or stage 2? Is urgency or emergency, and primary or secondary, and how you manage, what is your cell, and how you manage the patient. Case 2, it is 2 weeks old baby, term 38 weeks, day 1, post on omphalocele repair on IV fluid, not distress, well, no concern, and the blood pressure is 110/86. He covered with analgesia and antibiotics. So any volunteer or anyone want to write in the chat box? Okay, this the centile chart for the 38 weeks to 38 weeker. This is the post conceptual age 2 weeks. So you see here, the blood pressure is 99th percentile is 97/70, and our patient blood pressure is 110/86. So this is stage 2 hypertension. But the patient is asymptomatic and the patient is well, not distressed. And he's day 1 both on omphalocele repair. So whenever they call me in the NICU, I should go and see the progressive blood pressure chart. When I see the progressive blood pressure chart, this patient is not hypertensive before, all the reading is well, and he's covered with good analgesia, he's not in pain. So our diagnosis is neonatal hypertension, closure of abdominal wall defect as one of the causes of neonatal hypertension. Just few words about neonatal hypertension and closure of abdominal wall defect. The mechanism in closure abdominal wall defect is compression of the renal parenchyma, vasculature, or pressure on splanchnic or pelvic nerve supply. We suggest thiazide diuretics and calcium channel blockers, and the renin-angiotensin-aldosterone system is crucial to the normal renal development pre and postnatally, and ACE inhibitors may impair completion of normal development. So we should use ACE inhibitors and ACE inhibitors with caution in neonatal period because it's dropped the blood pressure significantly. This is one of the questions: which drug you should be used in neonate with great caution? It is the ACE inhibitor. This is causes of hypertension in neonate. Umbilical arch catheter associated with embolic or thrombotic events, congenital nephrotic syndrome, idiopathic arterial calcification, congenital rubella syndrome, bronchopulmonary dysplasia, pneumothorax, pain, and burst asphyxia, and adrenal hemorrhage. Also the ECMO and closure of abdominal wall defect. Patient in TBN can develop hypertension, and medication like vitamin D intoxication, theophylline and caffeine, and maternal drug use like cocaine and heroin. Case 3, this is a 12 years old child. This is 12 years old child present with 2-week history of headache, palpitation, diaphoresis, loss of weight, and the blood pressure 176/102, encephalopathic, and other examination is normal. What is your thought? Anyone can write in chat box. Okay, so this is stage 2 hypertension as the blood pressure is more than 140/90. There is signs and symptoms of target organ damage. The patient had headache, encephalopathic. So this is hypertensive emergency. Okay. This is hypertensive emergency. So in patient with hypertensive emergency, we should rush and admit the patient to the ICU or high dependency, and we should treat the blood pressure gently. And with this history, it is secondary because we have other symptoms towards the underlying diagnosis like headache, palpitation, diaphoresis, and loss of weight. It could be pheochromocytoma. So hypertensive emergency is often seen in secondary form. Encephalopathy manifests with headache and change in mental state and seizure. Pathophysiology involves disruption of autoregulatory mechanism of cerebral blood flow, require immediate evaluation and intervention. So we admit the child to ICU, high care, blood pressure reduction should be slow in controlled manner, and we recommend intravenous infusion like labetalol because we'll titrate the things and we drop the blood pressure gradually. This is algorithm of hypertension crisis, either hypertension emergency or urgency. Hypertension emergency, as we said, stage 2, we start with organ-dynamic, we start IV infusion. The first step, in the first 6 hours, decrease the blood pressure only by 25% of the planned blood pressure. And the second step, we decrease the blood pressure gradually to the blood pressure around the 95 percentile in the next 24 to 48 hours. Then we add their oral drugs. And the third step, more than 48 hours, we decrease the blood pressure to less than the 95th percentile. In hypertensive emergency, if the patient tolerates oral medication, we start with oral. If not, we give IV infusion or boluses. Few words about fibromyalgia. The mechanism of hypertension is catechol-induced. Although it is a rare cause of hypertension, has its unique set of management channels. Blood pressure needs to be stabilized until tumor can be surgically removed. Treat hypertension emergency with intravenous labetalol. It is well suited fibromyalgia because it is alpha and beta blocker. An oral drug of choice after you win the intravenous is alpha adrenergic blocker like prazosin. Workup, we need to work up the patient as our provisional diagnosis is fibromyalgia. We need to measure the serum catecholamines, metabolites like metanephrine and norepinephrine, 24-hour urine collection of catecholamine, epinephrine and norepinephrine. And we do a CT is rather helpful than the MRI, is recommended for the first line imaging technique and the MEBIG scan. And PET scanning has shown promising result as an imaging modality for fibromyalgia. Case 4. We consulted by ENT surgeon regarding 7-year-old male admitted for tonsillectomy. Their concern, high blood pressure. The child is asymptomatic child with normal development. The blood pressure is 130/80 on 3 different occasions, all above the 99th percentile for age, sex, and height. And the body mass index is 31.8. He is obese and not dysmorphic and normal genitalia. Anyone can comment about the hypertension and stage and what is the cause? Okay, so this is a patient with stage 2 hypertension. Is asymptomatic, so it is hypertensive emergency, and there is nothing in the history towards diagnosis, but the child is obese, so it's going with essential hypertension. So it is type 2 hypertension, asymptomatic hypertension due to metabolic syndrome. Our workup will be the urine dipstick for protein, stress, urine protein creatinine ratio is non-nephrotic range proteinuria, fasting blood glucose is 6 millimole, and hemoglobin A1C is 5.9, pre-diabetic, and the total cholesterol is high, normal renal function test and electrolyte, and kidney ultrasound is normal. So this is patient with metabolic syndrome, but we will start treatment. We go like all the measures of conservative reduction of the weight and DASH diet, but we should start treatment because this is patient with stage 2 hypertension. As we said, when to start treatment. This is the mechanism of hypertension in obesity. Due to obesity can cause hypertension due to hyperinsulinism, hyperlipidemia, because cause sympathetic nervous system activation, renal structural damage, sodium and fluid retention. Also, obesity can cause renin angiotensin system activation, affect the glomerular vasoconstriction, sodium and fluid retention, cause oxidative stress inflammation, cause vascular effect thrombosis, and endothelial dysfunction and vascular damage, which lead to hypertension. Case 5. This is 12 years old, previously referred by school doctor, neonatal period unpainful, present with very high blood pressure. It is 194/116 millimeters. Our laboratory values include the body mass index is normal, hemoglobin A1C is normal, urea and creatinine is normal, bicarbonate is normal, and potassium and urine MS is normal. Echocardiography was done. It showed left ventricular hypertrophy with no evidence of coarctation of the aorta. So what is your thought? Anyone can write in the chat box. Yes, it is stage 2 hypertension. Yes, and it is hypertensive emergency because the child has left ventricular hypertrophy. We discussed how we manage the hypertensive emergency. And okay, so the KUB was done. It showed normal kidney shape, but the right kidney is 7 centimeters, which is small, and the left kidney is 9 centimeters. Other reports is normal. So what is your thought with this? You have a stage 2 hypertension. You have very high blood pressure. It is incidental findings, and with target organ damage, ventricular hypertrophy. And when you did the renal ultrasound, you found unequal kidney, and the right kidney is smaller than the left. Yes, yeah. So this renal artery stenosis. Okay, so what is your next step to confirm this is renal artery stenosis? Yes, we did the Doppler ultrasound. Blood test that can be done. Blood test that can be done and give you a clue for the renal artery stenosis. Yes, we did the serum renin activity and serum aldosterone activity for this patient, and we found both is high, the serum renin activity and serum aldosterone. So this hypertension is stage 2, renal vascular hypertension, and we did the Doppler ultrasound, DEMSA scan. Why we did the DEMSA scan? To assess the function of the kidney, and we did the CT angio. And it showed that there is stenosis of the right main artery and its branches. So factor indicating a strong suggestion of the renovascular hypertension, severe hypertension, more than the 99th percentile plus 5 compared with age. Poorly controlled hypertension, you have a patient, you give 2 antihypertensive treatment or more, blood pressure is still not controlled. So think about renovascular hypertension, renal artery stenosis. Secondary symptoms of high blood pressure, like several symptoms, known or suspected previous vascular insult. Patient with syndromes, they have high risk of vascular disease like neurofibromatosis, tuberous sclerosis, Williams syndrome, and sign of vasculitis. And don't forget the chiasm, previous trauma or radiation, and patient transplanted kidney, and bruit here over the renal arteries, or neonatal period, renal artery thrombosis or umbilical artery catheterization. And the laboratories that raise the concentration of that, it would be renal artery stenosis, raised peripheral plasma renal, and moderate hypokalemia and metabolic alkalosis, but will not present on all patients, sometimes will not present. This bilateral renal artery stenosis is more common than unilateral. Medical treatment is, in most cases, is not sufficient, and it needs surgical intervention, either angioplasty with or without a stent, or surgical treatment. And we should avoid the ACE inhibitor as when writing the chat box. Case 6, and this is the last case. So I want to see if anyone writes. Okay, you want to show the previous image, okay? Someone asked to show the previous image. This is the CT angio. It shows that there is, this is the arrow here. It shows there is stenosis of the right main renal artery. Okay. Okay, case 6, and this is the last case, 11 years old, presented with history of long-standing headache for 3 weeks, and he was previously well, and there is no family history of hypertension, kidney disease, or similar condition, and no history of using traditional medical or illicit drugs. Examination, patient, oriented Glasgow Coma Scale is 15 out of 15. Vital sign is normal, apart from the blood pressure, which is 211 over 147. It is consistent with stage 2 hypertension, with evidence of target organ damage. When we do the ophthalmological assessment, we find that he had stage 4 retinopathy. And this is stage 4 retinopathy for this patient. This actually it is not our. It's not for our patient. I took it from the textbook, but our patient had stage 4 hypertensive retinopathy. You saw that there is cotton wool and exudate and the edema of the optic nerve. Urine Diagnostic was done, and it showed proteinuria of 1 cross, no hematuria, normal pH, and normal specific gravity without other abnormality. We did the urine protein creatinine ratio. It is non-nephrotic range. Ultrasound of the abdomen showed that the kidney is normal in morphology, but it's a bit, the length is a bit high length. It is 12 centimeter, and the left is 14 centimeter. It is above the normal size limit for the age of the patient, and it is hyperechoic. Laboratory test was done. It is. We said that it is stage 2 hypertension, and it is hypertensive emergency. So you need to admit the patient to the ICU or high dependency, and you need to drop the blood pressure in controlled manner, and you need to start intravenous infusion. Then you, with the same time, you investigate the child to know the cause. So as we said, the blood pressure is more than the 95th percentile. The 95th percentile for the patient is 121 over 76. And with the new guideline, it is stage 2, 95th percentile plus 12. So it is stage 2 hypertension with normal serum sodium, with low potassium of 2.7, normal upper limit of serum chloride, and the urea and creatinine is normal, normal estimated GFR, and the serum bicarb level is high. So what is your thought about this patient? This patient has metabolic alkalosis, hypokalemic metabolic alkalosis with high blood pressure. What is your thought about this patient? Okay. Yeah, someone wrote tubulopathy. Someone, it is, yeah, it is. Someone wrote to Barter and Gittelman to differentiate between metabolic alkalosis and hypokalemic metabolic alkalosis. In Barter and Gittelman, they didn't present with high blood pressure. Okay, this is one of the things that you should put in Barter and Gittelman. They didn't present with high blood pressure.
Some people are writing Lidl.
Yeah, I said that Lidl syndrome. Yeah, Lidl syndrome is one of the differential for this patient, and also the hyperaldosteronism. One wrote that hyperaldosteronism. So the differential between Lidl syndrome, it's right, hyperaldosteronism, either primary or secondary. Okay, so what is the workup that you need to do to differentiate? Yeah, we need to do the aldosterone level and renin level. Okay. Okay, we did the transtubular potassium gradient. The transtubular potassium gradient, it showed that you did the urine potassium, the serum potassium, the urine osmolarity, and the serum osmolarity, and you calculate the transtubular potassium gradient. And it was 5, which suggests that there is renal potassium wasting. TTKG in presence of hypokalemia, it should be less than 3. And in our patient, it was 5, so that suggests there is renal potassium wasting. So after that, we did the serum renin activity, which is low, normal value, it is low. And we did the aldosterone level, which is very low. And we did the serum cortisol level, which is normal. So this is going with what? What is your diagnosis now and how you confirm it? Anyone can write in the chat box. We did the aldosterone is level is normal, and the renin is low, also lower limit of normal. Yeah, it is Liddle syndrome. So how you confirm the Liddle syndrome? So it is hypertensive emergency and it is Liddle syndrome. We confirm Liddle syndrome by doing genetic tests for mutation of beta and gamma subunit of ENAC gene. And the unit and effective therapy, it is triametrine and amiloride for hypertension. When you use this, the blood pressure will improve nicely. But unfortunately, really we didn't have, because we just motivate for this treatment. Okay, this is this diagnostic algorithm for metabolic alkalosis. Some people, they said that Barter and Gittelman. So when you have patient with metabolic alkalosis, hypokalemic metabolic alkalosis, the first thing, you measure the blood pressure and you assess the hydration status. If the blood pressure is low or normal, you do the urinary chloride, and if it is more than 20, and or if it is less than 20. If it is more than 20, so there is chloride loss in the urine. So if the try to take patient active diuretics, Barter and Gittelman and hypomagnesemia. So it means that the patient with Barter and Gittelman, the blood pressure will not be high at all. It will be low or normal. And if the blood pressure is high, then at this time, the renin activity is low, renin and low aldosterone. So it is, you think about the aberrant mineralocorticoid excess like Cushing, licorice excess, and Liddle syndrome, and exogenous mineralocorticoids, and enzyme deficiencies. Secondary hyperaldosteronism, the aldosterone is high and the renin is high. Then you think about the malignant hypertension, renin-producing tumor, and renal artery stenosis. Low renin and high aldosterone, you think about primary hyperaldosteronism like Conn syndrome, bilateral adrenal hyperplasia, and carcinoma. So we reach the end of our cases. Home message that we took from this lecture: an appropriate size is required for appropriate measurement of the blood pressure. Don't forget to measure forelimb blood pressure at the initial assessment. Appropriate therapeutic intervention are increasingly expected to prevent morbidity, and often identify etiology allow for therapy directed towards pathophysiological mechanisms. And when this is not possible, medication choice should be governed by maximum benefit and minimal side effect. And any patient with symptomatic stage 2 hypertension or blood pressure more than 30 millimeters higher than the 95th percentile should be treated urgently in the emergency department or high dependency area and inpatient setting. And children with hypertension and chronic kidney disease, proteinuria and diabetes mellitus, angiotensin converting enzyme inhibitors and angiotensin receptor blocker is recommended as initial medication unless they are contraindication. We reach the end of our session, and I hope it is useful.
Thank you.
Thank you very much, Dr. Nesreen. Very illustrated, informative, comprehensive. وغايته نقول ختامه مسك يعني ما شاء الله عليكي. Well done. Excellent.
Thank you, Dr. Nesreen. It was an interesting session. I hope they get benefit from it. طيب دكتور عوض الله، دكتور أبو بكر، دكتور راشد.
السلام عليكم. دكتور نسرين ما شاء الله يعني كالعادة ما شاء الله very nice والله. Thank you very much والله excellent يعني ختام ومسك ما شاء الله. رفعت الكيرف للريجسترار ما شاء الله يعني ف well done excellent والله excellent. Thank you very much والله. Thank you.
Excellent presentation, Dr. Nasreen. Very elegant, very nice, very systematic approach. And the take-home message, I think, for all our registrars is to pay attention to the clinical presentation. History is very important. And when you do your physical examination, look at all the signs, whether the patient is obese, whether the patient is thin. Sometimes, you know, endocrinological causes of hypertension, such as thyrotoxicosis, can be missed. Just if you look at the eye and look at the patient in front of you, patient with pheochromocytomas that Dr. Nasreen was mentioning, they tend to be very agitated. When you are in the room, they cannot, you feel that there is, you know, the child is not sitting together quietly. So there are certain cardinal things. And when you reach the investigation part, you've already kind of, you know, made your where you think to the area that you're going to look for. So thank you very much for the elegant presentation. And I think this is very important topic that people should pay attention to. And it's one of the emergencies that people have to address it.
Excellent.
طيب شكرا لكم. We have Dr. Ahmed Al-Haj, President of Sudanese Association of Pediatrics in KSA. He just would like to have a word, small thank for you. I will let Dr. Ahmed in so he can thank you by himself.
السلام عليكم. محمد زين، كلام صوتي واضح؟
ايوه واضح دكتور احمد، تفضل.
شكرا قبيله النفرولوجي. السلام عليكم يا عوض الله يا دفعه. زمن طويل. راشد، دكتور نسرين، دكتور امام، كل المجموعه، محمد زين، فردا فرد، الحضور الكريم، يعني عايزين عن الشكر. شكرا لكم على المعلومات الغيمه والريفرشمنت. يعني الواحد كان فترة طويلة مع نيوناتولوجي، لكن حقيقة الكورس ده عمل لنا أزال الغبار على أشياء كثيرة جدا. فشكرا جزيلا وعايزين عن الشكر، وإن شاء الله ما حيكون آخر حاجة ولا ختام ومسك مع نسرين، لكن ما حيكون ختام إن شاء الله للمحاضرات للسودان وللناس اللي في السودان، وإن شاء الله حتتواصل الأكتيفيتيز والنشاطات. وشكرا لكم، وعارفين انكم حيكونوا عضد وساعد لنا في تقديم المحاضرات ومساعده الشباب في السودان، ودي خدمه لكل الناس السودان لما احنا نرفع ندعم التريننج بالنسبه لاخواننا وبناتنا اللي في السودان، فده بيساعدنا كثير لخدمه كل اطفال السودان. وكثر خيركم وشكرا كثير. بكره ان شاء الله موعدنا مع الاندوكراين، وحيكون اخر يوم في الاسبوع ده، حيكون باقي لنا الجي اي، حيكون another day. شكرا للحضور الكريم، تعبناكم كثير. very condensed compact course in 1 week, long time per day, من 4 ل 10 ل 11 مرات من الصباح. really it is hectic. شكرا كل الحضور الكريم. محمد كرار، شكرا كثير للتنسيق والترتيب وحضورك المتواصل. شكرا لكم.
شكرا يا دفعه، تسلم يا ابو حميد، ربنا يكرمك.
الله يسلمك، تسلم كثير.
شكرا دكتور احمد يا اخي، كتر خيرك يا اخي، الفرصه الجميله دي والله كتر خيرك كثير. وحقيقه محمد زين طبعا اخونا الصغير يعني ما مشكور يعني، لكن والله يعني هي ديد فانتاستيك جوب والله. محمد زين يعني ما شاء الله عليه،
ما في مشكلة والله بوجودكم
الله يديك العافيه.
يا راشد، نحن بنقول هذا الشبل من ذاك الاسد.
اكيد
وليس الفتى من يقول كان ابي. وما قاعد يمكن محمد زين قلت عليه وما قلت عليه. انا مشيت بيدياتريك، كان الانترنت بتاعي هو بيجايني، وانا مشيت بيدياتريك بعد ما اشتغلت بيدياتريك مع بروفيسور.
الله يديك العافيه يا دكتور احمد والله.
الله يحفظه يا اخي وربنا يديله العافيه والله. اي والله ان شاء الله اجيب مستمر والله.
الله يديكم العافيه يا دكتور راشد.
ان شاء الله اجيب ان شاء الله مستمر ان شاء الله باذن الله ان شاء الله.
ان شاء الله. شكرا لكم، شكرا كثير.
طيب اعتقد we can say good night وشكرا لكم.
شكرا يا محمد زين، ما قصرت.
مع السلامه. مع السلامه.
السلام عليكم.
السلام عليكم. السلام عليكم. شكرا لكم.